Respected chairpersons, dignitaries of the dais, and of course, regards to the chairs which were expected to have more dignitaries here. I am presenting a case of Axenfeld rieger syndrome which came to my OPD. From 3 years, she has been following me up. Uh, in fact, this is the picture of the Axenfeld rieger syndrome, what it can all involve. In eye, of course, it is posterior amylotoxin, peripheral anterior synechia, correctopia, iris hypoplasia, pseudopolychoria, but it can also be associated with cerebral hypoplasia, sensorineural hearing loss, craniofacial dysmorphism, dental malformations, congenital heart defects, and of course the redundant periumbilical skin. This is a case of Sonia, 20 years old. She is an athlete from Rohtak itself. She came to me with headache only. And of course, she was having pain around both the eyes since early childhood, which was insidious, dull aching, progressive, more in early morning, relieved on taking medications, and now often on severe headache. She was unable to speak and listen also. There is no other history of trauma, nausea, fever, any other ocular surgeries, blood and vascular disorders, palpitation, breathlessness, hypertension, diabetes, or tuberculosis. She had visited another ophthalmologist where she was diagnosed to have anterior segment dysgenesis and was prescribed the drops I have mentioned, latanoprost, brinzolamide, and timolol. Personal history: diet is mixed, appetite is normal, sleep is adequate. There is a family history, of course, of the father and the mother consanguineous marriage, history of similar complaints in the family. General physical examination was essentially all right. She is 170 centimeters in height, very well built, a smart girl in fact, but is deaf and dumb and is having eye problems. Her CNS, of course, was normal. Ocular examination, I will only mention the positive findings. The positive findings were, of course, the gonioscopy, the detached Schwab's line in all the four quadrants. Iris atrophy was present in both the eyes. Correctopia, reactive to light. Correctopia with pseudopolychoria was there in the left eye. The left eye was more affected than the right eye. The CD ratio, of course, was also increased, and then foveal reflex was normal. General background and blood vessels, they were also normal, but IOP was 26.4 and 24.5. This is the picture of the girl where you can clearly see the iris atrophy, the correctopia, and of course the polychoria. This is the UBM picture of the female. Of course, you can see the thinned out iris and the ciliary body and high insertion of the iris. This is the anterior OCT of the same patient, and these are the fundus pictures. This is the ultrasound, and of course on OCT the RNFL was reduced in both the eyes. Posterior amylotoxin is a clinical and histological term referring to displacement of Schwab's line anterior to the limbus in the cornea. Rieger described patients with congenital iris abnormalities including iris hypoplasia, correctopia, and polychoria, now referred to as Rieger's anomaly. Rieger anomaly associated with systemic findings such as dental, facial bone defects including maxillary hypoplasia, umbilical abnormalities, or pituitary involvement is known as Rieger syndrome. The combination of Axenfeld anomaly and Rieger syndrome is known collectively as Axenfeld-Rieger syndrome. The genetics, of course, are very important. 3 genes have been identified: type 1, type 2, and type 3. The general role of course, it is the transcription factors binding to DNA, control the activity of other genes active in developing eyes and other body parts before birth. They are important for embryonic development, particularly in forming structures in the anterior segment of the eye. The medical management, of course, is brinzolamide. 1% I am keeping her. She is nice. She is maintaining well. Surgical has not been planned as yet. Axenfeld-Rieger syndrome is a rare autosomal dominant neurocrystopathy that presents with a variety of classical ocular and systemic findings. Of course, the anterior segment dysgenesis is the main. The most common ocular features of ARS are posterior amylotoxin, iris hypoplasia, while some patients may manifest as corneal opacity and edema. The main pathogenesis of ARS is abnormal migration and differentiation of neural crest cells during the embryonic period, leading to multiple phenotypes. Axenfeld characterized by posterior amylotoxin and it stands adherent to the anteriorly displaced Schwab's line. Epidemiology and pathophysiology, I have just mentioned. The clinical characteristics, of course, are very important. As I mentioned, correctopia, polychoria, ectropion uvea, posterior amylotoxin, and increased intraocular pressure. The most common recognized clinical manifestations are, of course, iris correctopia and atrophy and posterior embryotoxin. Occasionally, patients have megalocornea and microcornea. The iris stands adherent to the Schwab's line, which was present in this case also in the right eye. The facial abnormalities, of course, are there. The dental abnormalities are there, but in my case, I never found any facial abnormalities and dental abnormalities. And of course, the case of empty-sella syndrome and arachnoid cyst have also been reported. Growth hormone deficiency and short stature have also been described, but this patient was healthily built. Glaucoma is seen in approximately 50% of such cases with ARS. Developmental arrest of the neural crest cells with a retention in the anterior chamber angle during gestation results in incomplete development of the trabecular meshwork. So the management includes, right now my patient is on only medical management. The surgical management, of course, has not been planned in this case, but you can always have surgical outcomes if the pressures are not controlled. Thank you very much.
Thank you, sir, for a very interesting